care and helping the patient make the right decision for them, but not dictating to them what they should do, these things set the patient up to feel more safe in their interaction with you and show them that you see them. In turn, they see you as an important part of their care and not just someone who makes them do stuff. It also creates a space where the patient will begin to feel safe asking questions they may have previously refrained from asking. It helps them to know that you are not going to judge them for their fears or their concerns. TIC acknowledges that trauma can affect people's neurological, biological, psychological, and social development. Did you know that the brain literally gets rewired when people are exposed to repetitive trauma? It changes the way input is received and how it's interpreted in the brain. This is why some folks have what we perceive as over-exaggerated responses to what we see as simple or uncomplicated experiences. And this is also where PTSD comes from. Which brings me to the next point, preventing re-traumatization. This is the overarching goal of all trauma-informed care interventions, to not trigger or activate someone and to not cause new trauma. As a gynecologist and a patient, I can say no one actually wants to come see me. No one is like, yay, it's time for my pap smear. I'm so excited. So my professional goal in life is to make a patient's experience with me be the least offensive possible. I also seek to arm them with knowledge about their condition, to teach them something they didn't know before they walked in, and to be seen by them as their partner in health rather than their health dictator. The most tangible way to start implementing trauma-informed care is physical safety. This is a relatively low-hanging fruit. We are talking well-lit parking areas, well-lit entryways and waiting rooms, and not positioning yourself in front of the door like I mentioned earlier. Everybody's physical space is different, so sometimes the best partner in this is folks who have experienced trauma themselves. This could be employees who are passionate about the topic and willing to participate, or patients willing to share their thoughts and experiences. You could even poll patients anonymously so there isn't a fear of being known as the patient who has a concern that they brought up. Other examples here may be music or sound machines in the waiting rooms to kind of mask conversation and to try to hide personal details being provided at the front desk. The next tenet for trauma-informed care is building trust. Trust comes from transparency, honesty, and non-judgment. This starts with the front office explaining what to expect, the MA explaining what to expect, the healthcare provider walking the patient through what exams they recommend and why, and then explaining care options. Because many patients come into the healthcare space already with some trauma, I try to provide both verbal and written information to all patients whenever possible. So if I'm doing a consult for painful periods, I have an educational dot phrase in my EHR for that. I only have to type 4 characters on the keyboard and boom, all of it pops up. And yes, this takes a lot of work up front to make these, but I can then use them over and over, and they allow a patient to digest what we discussed and when they get home in the safety of their own space on their own time. Next is to always be cognizant of cultural, historical, and gender issues that may be playing into a patient's interaction with the healthcare staff. This may mean their mom or dad had a rough time or even a bad outcome and they are skeptical in general, or this may mean a woman with a history of sexual assault being examined by a man and is very nervous about the power dynamic. It's about the non-judgment and all acceptance, and about creating a space where patients begin to feel safe enough with you to voice their concerns. And finally, TIC constantly seeks to recognize and address biases and stereotypes of all kinds. A trauma-informed approach to care acknowledges that healthcare organizations and care teams need to have a complete pictures of a patient's life situation in order to provide effective healthcare services. It's not always possible to get all the details all the time, so it's a goal and something to strive for and be aware of, kind of always asking yourself, what do you not know? What is missing for their patient to make their informed choice? Adopting trauma-informed practices can potentially improve patient engagement, treatment adherence, and health outcomes, as well as provider and staff wellness, and without increasing the visit time. It can also help reduce avoidable care and excessive costs for both the healthcare and social services sectors, and we'll go through some tangible ways to really do this during this talk. I'll also share data on how trauma-informed care and patient-centered decision-making can improve health outcomes. So what does trauma-informed care look like in real life? I will start with an example, C-sections. Trigger warning, I am going to show pictures of actual C-sections, so if this activates you in any way, please feel free to look away. Now, while this content is generally designed for outpatient care, bear with me for a few minutes while I explain why I'm using this inpatient example. Most of us know what a C-section is like, either because we've had one, we know someone who's had one, or we've seen them on TV. They tend to look like this. Blue drape, the birthing person is not seeing anyone or anything, and they are certainly not seeing their baby after the delivery. Or maybe they're lucky enough to be shown their baby like this. Usually the baby's warmer is not even an eyeline view to the patient. The entire OR setup is arranged to be convenient for the care providers and not the patient. But what if it could be done differently? When implementing trauma-informed care, you always have to figure out how to navigate the dynamics in the environment in which you work. So in this case, it's an operating room. It's sterile. Certain things are not negotiable, but a patient's goals, fears, and priorities should be considered here too. I first began modifying the C-section space around 2012. Nowadays, there's a lay term for that called the gentle or family-centered C-section. It begins with birth choices, like do they want a clear drape or a blue drape? Do they want to watch the birth or not? Do they want to have the baby delivered up to their chest or taken to the warmer first? Do they want to play their own music in the OR, have our music play, or have no music at all? And I'll tell you over the years what people choose and why is very interesting to me. For example, I had a patient recently tell me that they want the baby taken to the warmer first because their first baby had breathing troubles and it was very scary to them. So their priority was safety of the baby first. I even had a patient share with me recently that she would feel too vulnerable playing her own music in the OR, but would feel great if we played ours. You never know what is important to a patient and where their priorities are unless you ask. And this is why it's so important to offer choices for anything and everything you can. That includes treatment options, but also even positions the patient is in for various exams or options for collecting certain tests. This is a picture shared with permission of an ICU nurse who was having her 6th C-section. I had not done her other deliveries, but that's me on the left in the picture and my partner photobombing with our thumbs up. Not once before was she offered any kind of choice for her C-sections. When I reached out to her to ask permission to share this photo, even though the C-section was 7 years ago, she is still over the moon about that birth experience. And for me, it adds like 1 extra minute of my life to offer these options. And mostly that's because if they want the baby delivered up to their chest, I have to wear special sleeves and then change my gloves and change my sleeves. And we usually sing happy birthday, which facilitates delayed cord clamping, so everyone is winning. Truly, it's minimal effort on my part for a monumental experience change for the patient. An important part I want to share about those gentle or family-centered C-sections that is most relevant to anyone interested in trying to start practicing trauma-informed care in any space is that the journey was not always easy or quick. In the beginning, the neonatal nurses who care for the baby were very resistant. As you can imagine, they were very used to assessing the baby in the warmer, where there's great lights and easy access to every aspect of that baby, rather than the birthing person's chest hanging under a surgical drape. So I asked them to share their concerns and addressed each and every one of them. At first, I started out with something like, well, how about we give it a try, and then afterwards we can debrief and see what your thoughts are. It took time, exposure, and continuous gentle pressure, and of course, repetition, repetition, repetition. Eventually, the anesthesiologist noticed how content the baby was on the birthing person's chest. The pediatricians got excited when they saw that as well, and the NICU nurses eventually got used to their own practice change, assessing the baby for the first 5 minutes on the patient's chest. And of course, we're all patients too, right? As many of our labor and delivery nurses and nursery staff started having babies, and some needed C-sections, they wanted this type of birth experience for themselves. And if you're going to treat yourself this way or request this type of care for yourself, shouldn't you be advocating it for your patients as well? In grand total, it took about 1.5 years to have this family-centered C-section be a standard expectation. But when I left Lakeland Hospital in St. Joseph, Michigan in 2021, this was the standard assumption for nearly all C-sections unless otherwise stated. To get started in implementing trauma-informed care, like baking anything in the kitchen, you need the right ingredients, the right timing, and you have to use the right approach, have plenty of patience, invest the time, and be persistent. I'll sprinkle baking pics of my kids throughout the years in these slides to drive home the point and for a little bit of cute levity, but this is a pic of my first son there in the middle when he was about 5 and 2 of his friends who were working on the right ingredients and figuring out the right or maybe wrong approach. It starts with a decision that your organization is going to do this. As you'll learn in this talk, you don't just learn a step-by-step process, and once you've made it through the list, you're done. This is an ongoing dedication to improvement in how you deliver care. You then need to identify key stakeholders. These should be folks at all levels of the patient care experience, which includes security, front office staff, medical assistants, nurses, providers, and anybody else important to your organization that is both clinical and non-clinical. It should include people with lived trauma, but it should also include senior management. Some people may complain about this as there may be trust issues with administration, but having members of admin involved shows the organization that trauma-informed care is valued at the highest level. Additionally, with senior management present, the authority to make change is always there. In some instances, there may be strong resistance to including senior management because of the potential for those trust issues. However, the work group is the place where some of these divisions can be breached, and that sustaining fractions and not working together only contributes to the problem and undercuts the effort. Having people with lived trauma involved, either because they work there or because a few patients are passionate about improvement within the system, is really important and truly invaluable. I always say patients have taught me how to take care of them more over the years than I ever learned in my formal training. One of the most important tenets in practicing and implementing trauma-informed care is to never stop learning how to do it better. I am always evolving and modifying what I do based on what patients say to me or how they respond to what I do. In our process of implementing this gentle or family-centered C-section, we got this list of folks involved. It was not easy at first. It started out with that skepticism, like, why do we have to do this? What is the point? This is where that gentle persistence is key. I continue to emphasize that we are still doing our jobs. I'm still performing surgery. It's still sterile, and the NICU team is still assessing the baby. We are just adjusting how we do it. I also reemphasize that we are doing this for the patient, to give them an experience they want, a way to help them restore some of the power they may have felt they lost in their last delivery. Choices, when able, in any space also help the patient build with you a relationship of respect, compassion, and mutuality. This is a picture of me in the back there with one of our labor and delivery nurses who requested a C-section for her first delivery. We went through all her birth choices and she was thrilled with her experience. She felt empowered and like we were there for her, and not how so many women feel, like they are there for us. Then once you've made a decision that practicing trauma-informed care is important to your organization, you have to have regular meetings and create benchmarks to determine how you are going to meet those goals. There are many published ways to do this, such as the Plan, Do, Study, Act model, where you introduce the idea of change, form a team, set aims, establish measures, select changes, test and implement those changes, and then spread them to others. Similarly, for the Trauma-Informed Care Initiative in any organization, early steps include acquiring foundational knowledge, generating buy-in, and ensuring other elements of readiness. The job of this working group of important folks trying to implement trauma-informed care within your organization is to gather information, to identify strengths and challenges, recommend priorities for change, develop solutions or action steps in these priority areas, monitor results to ensure the process is moving along, and propose additions or changes in the policy in order to institutionalize trauma-informed practices. Once you get these steps going, you can become a pretty well-oiled machine and get things done, like these guys who eventually got the process figured out. Now, that's all fine and good about C-sections and birth choices, but how do you get trauma-informed care into a 10 to 15-minute office visit? To begin thinking about how to start practicing trauma-informed care, I fall back on that old adage, do unto others as you would have them do unto you. Everybody on this webinar is a patient. Everybody here has their own care provider. Maybe you see them once a year. Maybe you have several providers for several different conditions. Take a moment and think about when you were in your healthcare provider's office as a patient and it didn't go quite as you would have liked. Did you feel safe? Have you ever been surprised at an office visit? Like maybe you came into the office thinking it was going to go one way, and when you got there, they told you it has to be something else. Like what you were thinking is just going to be getting birth control refilled, and the doctor says you need a pelvic exam. Or if you go in for your wellness exam and you didn't realize it was time to get your blood drawn. These seemingly simple things can be very re-traumatizing to anyone who has had any kind of trauma in their past. Or maybe it's just that nobody likes speculum exams or needles, and certainly not without a little warning or time to prepare. So that brings ingredient number 1, setting expectations. There are 1,000 ways to do this, and you have to figure out what works best for your space. For example, you could have your office staff or whoever takes your phone calls and schedules your appointments have set scripts that the whole clinic helps create, which helps generate buy-in about each appointment type, explaining what the patient can expect when they arrive. In modern times, this could be sent through the EHR portal to the patient like this. This is an example of one such document that we use for our prenatal patients in my office. This was actually created by our MAs and nurses. I say that specifically to say that sometimes the greatest way to lead is to delegate, which also helps generate buy-in. Just because you all may be the ones most passionate about trauma-informed care does not mean the burden of implementing this needs to be entirely yours. Setting expectations and preparing the patient whenever possible for what to expect also serves to ease fears the patient may have coming into the office. This also serves as the first step towards a trusting relationship, that the patient won't be surprised. that they will be warned in advance what things are going to happen so they know what to expect when they arrive. Setting expectations isn't just over at the first phone call or portal message. It continues throughout the entire visit. So when the patient checks in, the front desk should explain what will happen next, who will call them, and from which area of the waiting room they will be called. The MA, when they bring the patient back, should introduce themselves, explain their role, what to expect, and when to expect the provider, including realistic expectations about how late the provider may be running. Which brings us to ingredient number 2, honesty and transparency. How many of you have been a patient where the MA brings you back to the room, maybe even asks you to get changed into a gown, and then you wait, and you wait, and you wait, and no one tells you how much longer you can expect to wait? It's really unpleasant, right? Now, wouldn't it feel better if the MA says to you, the provider's running about 20 minutes behind. Please don't get undressed at this time. I will be back when it's time for you to get undressed. Or even adds, would you like a glass of water while you wait? While no one is excited about waiting 20 more minutes, it's the honesty and transparency that again helps build that trust. The next ingredient is explanation and choices. We all like options when we're decorating our cookies, right? As I already said, explaining everything in every healthcare setting for every step and for every person the patient interacts with helps build that trust. That's true too in the exam room. Explaining to the patient what aspect of the exam you recommend and why, and asking the patient if all of that is okay or if they have any questions about any of it is so empowering. Also, offering choices during exams, during blood draws, even getting a patient's blood pressure or weight. Can they look away when they get weighed? Do they have to be weighed that day? Which arm would they prefer to get their blood pressure on? Would they prefer to collect that STI swab themselves or have you do it? These choices are simple, but give the power back to the patient. And this brings me to the next ingredient, empowerment. Empowerment begins by making that safe space for the patient, or in this case, for your son to make his choice about baking with only his apron on, and creating an environment where they know what to expect with each step and is strengthened by offering them those choices. This also includes treatment choices with an explanation about the pros and cons of each choice because the patient may have different priorities than you think they should have. In my world of gynecology, one common scenario here is birth control. I may think the most effective is what's best, which would be IUDs in the arm implant, but a patient may prefer something they can stop quickly. Or maybe they disclose that they fear pain, at which point I can share with them pain management choices they may not have known they had. And this brings up the other aspect of empowerment. Whether you are aware of it or not, we always have a power dynamic in clinic, right? Everyone who works in the clinic has a power over the patient. We decide where they walk, where they sit, when they are seen, when the examining room door will be opened, when we will request them to get undressed. For some with a history of trauma, that alone can be re-traumatizing and a source of fear and heightened emotions. And that type of perspective will make patients less likely to retain the information we share with them. That is why, in my lifelong effort to work smarter, not harder, I recommend information on commonly encountered topics with patients that you can give them to read and digest at home in their own comfort when they have the power. Like this handout, this first part covers the various types of IUDs available and expectations with each one, and the other part summarizes that recent CDC statement that came out in August on pain management for IUD insertions and also lists what we offer in our clinic. Yes, it took effort one time in the beginning to make this, but now everyone in our clinic can use this to give to any patient who asks about IUDs or is scheduled for an IUD insertion. And it takes 4 keyboard clicks to get all of this. Simple. Patient-centered reading material that is designed for the patient population is important, as verbal plus written summaries of healthcare visits may actually mitigate the effects of limited health literacy. So you can improve patient engagement, understanding, and treatment adherence by providing them with reading materials for whatever you want them to know. So we've got these 4 ingredients already, but the other important ingredient is the clinic space itself. What does it look like? What does it feel like? Or in this case, what does it taste like? No, I'm kidding, but it is about the experience patients have with us. What is it like when patients enter your space? I remember being a patient in my own clinic when I was pregnant with my second son. I stood in line behind 3 other patients. Never once did the front office staff look up. She just said, "What is your name and date of birth and who are you here to see?" Typed some things into the computer, then told each patient they can have a seat. It was like this. Several minutes later, when it was my turn, she said the same thing to me, never looking up until she heard me say my name. And then she said, "Oh, hi," and looked up and smiled. And it immediately turned into this. And I said, "There you are." It's so important to train your office staff to be welcoming, kind, and gentle with every patient. This is one of the most important aspects of creating a space that feels safe for your patients. You can see in this bottom pick as well, there's a sign emphasizing there on the left that the patient is the most important reason we are here. The last ingredient you have to include to lay that foundation for trauma-informed care is humility and responsiveness. That includes a willingness to understand there is always something to learn and being humble enough to acknowledge it. This is where I say again, patients have taught me over the years about how to take care of them way more than I ever learned in training. Because when you choose to practice trauma-informed care, you are always on the lookout for ways to improve. The term cultural humility was first introduced in 1998 as a dynamic and lifelong process focused on self-reflection and personal critique and acknowledging one's own biases. It recognizes the shifting nature of intersecting identities and encourages ongoing curiosity rather than an endpoint. Cultural humility involves understanding the complexity of identities, that even in sameness, there is difference, and that a clinician will never be fully competent about the evolving and dynamic nature of a patient's experiences, but is always willing to learn. So now that you have the basic ingredients needed to create trauma-informed care, let's discuss how to make that happen and how to navigate resistance to making this change. The first thing is to understand why people may be resistant. One of the most common is, it's new. Change is hard, right? Everybody gets used to their routine, and whether you admit it or not, most of us really like being so comfortable in our workflow that we don't even have to think about the steps involved. This is the Kubler-Ross change curve. Most people know her for the 5 stages of grief, but these stages of change are what most of us experience as we travel through anything new, whether it be at home or at work. The next reason why folks resist change is perceived loss. This is the first half of the Kubler-Ross curve, where people really resist and spend a lot of time focusing on the past and what they perceive as being lost. This is things like comfort in the known and using less brain power since they're so used to their old workflow. But it's important when you are trying to implement change that you recognize this is a normal and expected part of the process. The next is effort. When doing anything new, it takes effort, right? This is the frustration part of that Kubler-Ross curve. Then there is fear of judgment or fear of failure. What if we aren't very good at it at first? What if someone hears me try this new approach and makes fun of me? What if I mess it up? There are all normal parts of discomfort that we all feel during this change process. Changing too many things at once can also lead to apathy, frustration, and depression, so it's important to consider this when deciding what you want to change. Maybe only tackling 1 or 2 things at a time and considering a staged rollout of change would be better in your space to minimize the depression part of this curve. And then there is impatience. This often results from being unclear about what the benefits of the change will actually be. It's important to really emphasize and lift up what the end goal is here. What are you trying to accomplish? What benefit can the participants see or experience? It's wise to make this clear in the beginning and re-emphasize the benefits and purpose of your approach regularly during huddles or meetings. Once you get past the first half of this change curve and work through that depression where folks feel a lack of energy, which requires regular check-ins or meetings, re-emphasizing your purpose and tasks and transparency in your plans, folks will then start buying into this flow. Then you get to the upward slope of this curve where everyone starts focusing on the future and on what can actually be gained. This is where the change becomes permanent and folks become unconsciously competent at trauma-informed care. Then there are specific issues with FQHCs that you have to take into account if you work at an FQHC. These extra layers need to be addressed when trying to implement trauma-informed care and include the unique charting requirements for Medicaid reimbursements. And these next 3, which are not uncommon in all clinic settings, trying to practice trauma-informed care when needing to involve interpreters, when patients have significant social needs that can hinder their healthcare access, and staff turnover, which can add an extra layer of struggle if you are trying to train new folks in trauma-informed care all the time. So now that you have the ingredients needed to create trauma-informed care and you have some common reasons for resistance, as well as some unique issues related to trying to implement trauma-informed care within FQHCs, clinics and patients with unique social needs, let's unpack ways to get trauma-informed care into your clinic and how to navigate some of those common no's so you can get to your final product, or in this case, a sourdough baguette. So let's start with your physical space. This is the first contact patients have with your clinic and the culture that you are trying to create. What does your waiting room look like? Is it cramped? Is there music? Any visually pleasant pictures or paintings? Any educational material that patients can read while they wait? What about patients who bring kids with them? Do you have anywhere where they can let their kids play and get a little relief? Some clinics can budget this type of stuff and others cannot. This is my clinic's waiting room. I tried to get this funded in our budget and we tried various ways, which is our first no for today. But ultimately our clinic could not fund this, so I saved up and bought these myself. Good news is they're tax deductible. And I recognize not everyone can afford this, but there are many creative ways to fund some of these things, including many grant opportunities, especially for FQHCs who serve the underserved. Folks have commented over the years how nice it is to have something like this to keep their kids occupied while they wait. It's just one opportunity to help a person have a little less stress in their day. And then there is your front office staff. They represent your entire practice and are often the first interaction patients have with your organization. How do they interact with the patient? Do they act neutral and like they're just trying to check the boxes and get through their day? Or do they see the person in front of them? Do they smile? Are they welcoming? What do they say to the patient? Do they reveal anything personal about the patient in front of others in the waiting room? Working on modifying any of these things is free. But that doesn't mean you won't get a no when you work with your front office staff to create a warm, welcoming, and safe space for your patients. Like the difference between this first scenario and the second one, having your staff see the patient, look at the patient, and provide a warm and welcoming entrance into your space matters. For folks with a history of trauma or those adverse childhood experiences or ACEs, this can be especially protective. I know that sign in the bottom left corner is hard to see, so I'll zoom it in here. These are things that are easy to place in your waiting room and are there for all patients to see. The fun part about modifying this approach that the front office staff is taking is that once you get through that first half of the change curve where there's resistance, they actually enjoy it. The patients feel more welcomed, there is less frustration or anger, the staff feel better at the end of their day, and then you get that buy-in from the staff. In our office, they even started doing this on their own. They put a new joke up on this whiteboard every week, and many patients, especially the OB patients who are there frequently, have said how much they look forward to seeing it when they check in, something so minor that can bring so much joy. All these things can set the stage for a great and affirming visit. So how do you get the entrance to your clinic or your space and your front office staff to start practicing trauma-informed patient-centered care? These steps are how you can get all of your staff involved in trauma-informed care, and it begins with training. Training and education for all staff about trauma and the impact trauma can have on a person's perspective and experience when they engage in your care. This can be done with presentations, watching training videos, or hiring experts to teach you. The next is creating a work group. This work group should involve someone at each level of care within your clinic, and it's ideal to invite folks to volunteer rather than to assign them, so you can seek out those who may be passionate in this idea. This is where involving administration or senior leadership is wise to consider, as I stated before, because it highlights that trauma-informed care is valued at the highest level and the power to make change is present. Consider including those people with lived experiences with trauma as well, because this unique perspective can give you that what it's like to be a patient perspective. It can be hard for those of us in the trenches every day. They can walk through the lobby or the waiting areas. They can review signage and provide perspective on what feels safe and welcoming. The purpose of the work group, as stated before, is to gather information to identify strengths and challenges, recommend priorities for change, develop solutions or action steps in priority areas, monitor results, and propose additions or changes to agency policy to institutionalize trauma-informed practices. The members of this group are also in charge of sustaining momentum across the organization and modeling that practice. The most successful work groups send out regular updates about membership, process, activities, priorities, and proposed recommendations, along with information about trauma or TIC, such as articles, video clips, fact sheets, etc. These missives are also an opportunity to recognize exemplary practices observed in the workplace and to disseminate new ideas or concrete examples that staff can use. Some of our favorite work group communication tools have been electronic newsletters, but a simple email will suffice so long as it is regular, informative, and invites feedback. To encourage staff input, it can be helpful to create an email address for the work group specifically, and that serves the dual purpose of institutionalizing the group and ensuring that no one person is solely identified with the effort. One of the biggest resistance to training is requiring it outside of work hours. If you prioritize this way of practicing medicine, you have to consider, the work-life balance of employees and ensure they are paid to do this training, which is best during normal business hours. Because if you want your staff to practice trauma-informed care with their patients, you should practice trauma-informed care with your staff, right? Work groups can be challenging to manage and sustain and be some of your earlier no's. Some of the difficulties are preventable by considering membership. It's very important that members have different roles, but that means it's inevitable that there will be power differences and issues surrounding relationships. In large, complex organizations, individuals may not necessarily know one another. It helps to know ahead of time that the work of the first few months may progress really slowly until relationships start to form. More challenging are inevitable power differences if management or senior management is represented along with the clinical staff. The advantages to including those managers are manifold, like I stated before. And without that, work groups can just spin their wheels all day long, coming up with ideas and priorities that are subsequently ignored or rejected by leadership. Another issue is group size. Considering the discussion and tasks involved, the optimal group is comprised of usually 8 to 10 members. However, work groups may need to be larger to represent constituencies in the organization and to ensure reasonable attendance at meetings. If the group is larger, the attendance remains high. Subcommittees can also form to tackle different tasks. Recruiting is best as voluntary, like I stated earlier, but this may not get someone from each role. So they could be assigned, but this could be perceived as favoritism and may not represent different perspectives. It may also be best to limit duration of service. Limiting duration to about 6 to 8 months seems to work pretty well, at which point the group can revisit the structure, the membership, and the process. The TIC initiative will be ongoing, but membership in the work group need not be a long-term commitment. In fact, some organizations rotate membership regularly to give more staff a chance to participate, bring in those new ideas, and reduce the burden for individuals. This can also help encourage buy-in as everyone has a chance to have their voices heard. It's important to have some continuity in the group, however, and to set up priorities to work from so that it does not feel like starting over as the membership changes. Next is considering having some kind of technical assistance. Many work groups find it helpful to have support, at least initially, from outside the organization. This can increase credibility in the early planning stages, as well as help with structure and manage power differences or conflict. Ideally, an outside facilitator phases out as soon as possible, providing any additional consultation only periodically. Even with outside assistance, someone in the organization will need to set up those meetings, send out reminders, write the agenda, facilitate the meetings, take minutes, etc. Management's commitment of staff time for a designated point person is important. This role can rotate, but we have found it works best when the point person is a committed champion for trauma-informed care, is relatively well-versed in the concept, has the ear of leadership, and is respected by colleagues. Next is generating that buy-in. Individuals typically join the TIC work group because there is something about it that resonates with them, either in their own experience personally on or off the job, or in their experiences with individuals they encounter in work. It's important to honor, capture, and use this immediate sense of what is important. One idea is to start the first work group by asking participants why they want to be in the work group and what they believe the organization can do to be more trauma-informed for both the workforce and also individuals seeking or receiving services. Typically, you can get enough material from this initial conversation to drive priorities for about the first 6 months. However, it's also important to be sure that other staff not in the group have an opportunity to feed into the list of immediate issues, either during brainstorming sessions as part of training or in their teams, staff meetings, or focus groups convened for this purpose. Generating buy-in is crucial in implementing trauma-informed practices in the clinical space. In our experience, the issues that surface first are surprisingly similar across wide ranges of organizations. Activating clients in the waiting room or in the phone, in a confined space or in their exam room, and the need for training in an effective and trauma-informed response. Lack of protocols for dealing with crisis situations that in themselves can be extremely destabilizing to staff. Other physical safety issues that affect staff and sometimes clients are also easy to elicit. Simple things like poor lighting or malfunctioning locks or challenges accessing crisis services when the need arises. In complex organizations, issues are typically emerge related to communication and power dynamics within the system, such as lack of transparency in decision-making, personnel practices that generate anxiety, lack of communication and a sense of respect or mutuality between different programs or divisions within the organization, and lack of teamwork. By acknowledging and working within the experience of the workforce immediately, it's like tapping into a superpower, and the TIC initiative can gain buy-in. This is particularly true if there are simple steps that can be taken to resolve concerns that surface. Often these opportunities relate to physical safety. Common examples include better lighting in parking areas, like I said before, a buddy system for walking out to the parking lot, or having a list of emergency numbers printed and laminated to help staff feel safer. These examples are high-impact, low-cost results, also known as low-hanging fruit, and help your staff trust in your implementation plans. They are usually simple, inexpensive, and easy to accomplish, but they can make a big difference by sending a message that staff concerns are being heard. Because again, if you are practicing trauma-informed care with your patients, you will also begin practicing trauma-informed care with your staff. So moving through a clinic visit about how to navigate the no's, try to think about it as if you are a patient. Usually in the flow of outpatient office care, the next thing that happens after a patient is called in from the waiting room is taking their vitals. For most, this often involves getting on a scale. In fact, it seems most offices have a blanket policy about weighing all patients. As a patient, I personally have only been to one office in my life where they didn't require my weight, and she was a surgeon who operated on me, so I was surprised, but honestly loved it. All the others have walked me right down the hall, straight to the scale, and said something like, "We'll stop at the scale so we can get your weight." Sound familiar? I would like to push back on this and ask you all, do you really need every patient's weight for every visit? As a gynecologist, I can say no. We actually rarely need someone's weight for their care. There are certainly instances in which we do, such as weight-based medications like methotrexate. But with most of our visits, the weight of a patient actually doesn't play into their care. This is, of course, not true with weight management-based visits, but I am speaking about overall care. Even as an obstetrician, where it is standard to weigh every patient at every prenatal visit, do we really need to do that? After all, it's total weight gain in pregnancy we monitor and counsel on, not particularly weight at each visit. And then there are healthcare system requirements. What do your health systems require for vitals? Do you know? In my health system, it's 3 vital signs, just 3, but it can be any of the vitals, such as heart rate, blood pressure, pulse ox, etc. We actually don't have to get a patient's weight. I would encourage you all to think about this too. Here's a tiny sign next to a scale in the MA explaining to the patient that they don't have to be weighed today unless they want to. It's hard to see, so I will enlarge it in a much prettier version available for free from the HCET website here. Why does it matter, you ask? Why should a patient care if we weigh them or not? Think about someone with a history of an eating disorder. It can be re-traumatizing to have to see their weight. Or what about the average person who would like to lose a few pounds and just doesn't want the reminder today? What about you? Again, think about when you are the patient. Have you ever gone to a provider's visit, been asked to get on the scale, and thought to yourself, geez, I wish I didn't have to do this today? In fact, research shows that patients are less likely to seek out care if they know they will have to be weighed. Some people counter-argue to this that if the patient doesn't want to be weighed, they should just say so. But that makes a lot of assumptions about that patient, that they have never had their voice taken away from them, that they have the agency to speak up and the confidence to do so. Many have a fear that if they speak up, they may be negatively judged or that that judgment may impact their care. So consider having signs out that demonstrate this, like that sign by the scale, or even something like this. A post that someone shared on the platform formerly known as Twitter last year and featured on the Today Show, where she went to her annual exam and noticed these cards at the check-in counter. In that office, anyone who didn't want to get weighed could just take this card and hand it to the MA and never have to say a word. She said, I felt really seen and validated and grateful. At the time of that article, she had 27,000 likes and 3,600 retweets. Something like that gives voice to people who truly may feel voiceless in our spaces. As we're all busy in clinic, if the MA doesn't have to weigh the patient, that is less time in the MA's workflow. So that's an easy win. You can come up with protocols about who needs to be weighed, a card like this in the slide that the patient can take from the waiting room and hand to the MA if they don't want to be weighed, or like this one that HCET has created, which is accessible for free, or a statement in each exam room that explains that depends on their visit today. We may ask to weigh them before their visit is over, but the scale is an easy place to tangibly practice trauma-informed care. When the MA calls a patient from the waiting room, how do they call the patient? Are they using Mr., Miss, Mrs., and last name? Pitfalls with this could include people recently divorced who may cringe at hearing Mrs. Once the patient walks in, is there small talk of any kind? Like, how have you been today? Or did you have any trouble finding us? Or is it just awkward silence? Setting some verbiage here for a few routine statements can be really helpful. Again, think about times when you have been the patient, when you have been called from the waiting room, when you felt welcomed, calm, and peaceful. What were those interactions like? Or on the contrary, when you felt that things were impersonal and as though they were just trying to get their part of your visit over with, what was that like? If you work in healthcare in any capacity, you have at least some power, and I would even argue that you have the responsibility to help make a patient's visit in your space uplifting and empowering. Does your MA or LPN ask the patient to get undressed before you even meet them? In some clinic spaces, meeting a patient dressed is a luxury and just not feasible. And in that setting, there are certainly good ways and bad ways to keep the clinic flowing. A good way here would be to have verbiage the MA says that specifies why the patient is being asked to undress first, what the exams are the provider may want to perform, asking the patient if they have any questions about that, and then stepping out of the room. Another one is to let the patient know the provider will knock before they come in. This can be reassuring to a nervous patient who fears someone may barge in while they are in the middle of getting undressed. And I know that seems silly, especially if we are about to do a full physical exam, but to some patients, they really need to feel that control, that they will be given the opportunity to hide their underwear in the folds of their clothes and can be seated on the exam table before the provider walks in. If you need your patients undressed before you see them for your workflow, consider doing some work up front with your MA to set scripts for each type of visit about what the MA should say and what the exams the patient can expect. Yes, this involves some extra work up front, but it makes a world of difference for the patient when they know what to expect. And by proxy, it makes a world of difference for us when patients perceive our transparency and honesty and feel less stressed because they have been informed about what to expect. If you have the luxury in your clinic of meeting the patient dressed before they get undressed, consider doing that because no one feels the most empowered in a gown and sheet. Most people don't want to share their concerns with no underwear on. Another opportunity for either creating fear or helping to calm someone is the room itself. What does the room look like? What items or instruments are out for them to see? Sometimes having certain items out can cause stress to a patient, even if the instruments are out all the time and only used when needed. For example, if you're a pregnant patient coming in for your routine OB visit, you walk into the room and you see this, a gown and sheet on the examining table, and this, a speculum and swabs out as well. What do you think is going to happen today? You think you're going to be asked to get undressed, right? Even if we as the providers know they are not going to need to be undressed for this visit, the patient may be experiencing unnecessary stress simply because of what they see. This is our clinic, and we make a point to only set out the gown and sheet when we know the patient will get undressed, but the instruments you see here are always out. This is for an easier workflow for our providers, but for the patient, it could be a source of that unnecessary stress. Maybe it's best to let them know at their first prenatal visit that these instruments are routinely out and not just specifically for their visit. I'll let you know that this workflow is something we still need to work on in our clinic. I share this to say practicing trauma-informed care is not a path to perfection, but rather a willingness to always learn what you can do better. You won't be perfect at it. You just have to be open to learning and changing to do better. Do you have any educational material on the walls for them to look at while they're waiting? Any artwork or something calming or peaceful to look at? I guarantee you patients are looking all around that room when no one else is in there. So what do they see? Do you have anything on the ceiling for them to look at when they have to lie back for an exam? Something like this. These are light covers we have in our exam room. Just a little something to distract patients during their exam. Distraction is actually a fantastic method for pain relief and could honestly be its entire own talk, but visual distraction can be helpful when trying not to focus on parts of an exam. Another important source of providing trauma-informed care is patient education. Yes, we verbalize what our assessment and plan is with our patients at each visit, but the truth is the clinic visit is not a great situation in which to retain everything as a patient. As I've stated before, this is because patients may already have heightened emotions or may be stressed or nervous. One of the most important things a clinic can do is provide written information to patients. And if you have written information already for patients, it's recommended to be reevaluated once in a while to ensure you're writing it the way you want and that patients are getting the information they need. Be intentional about what you're providing to them. Written summaries of your care plan or generalized education about their topic of concern helps them feel more heard and can clear up any potential misunderstandings the patient may have had but didn't mention to you during the visit. This happens sometimes for a variety of reasons, some of which include the patient feeling embarrassed or ashamed that they don't really get what we're saying. So written information helps them have that on their own to digest at home. Here are some pictures of various educational dot phrases I share with patients. In RHR, I just type up a few keyword clicks, like I said before, and all this text shows up for them in their after visit summary. And yes, it takes time up front to create these, but they are invaluable to patients and can be used over and over again. And why does this type of written information matter? Studies show that patients don't actually recall much of what we tell them during this office visit. And that's the statistic that's up there on the right-hand side. On average, only 30 to 60% of all patients remember what we discussed after their visit. And around 15% of patients can't remember anything. This demonstrates how important post-visit written information is for patients to process later on their own time, and in the safety of their chosen space. One of the no's often shared here is the time it takes to make these. But all providers can be involved in this, and topics of interest can be divided up among everyone in the work environment, whether that be a clinic or a hospital, to make these educational handouts. The burden does not need to be with only one person. So back to this infamous change curve. No one wants to add more to their workday when starting something new. If staff perceive that implementing trauma-informed care is going to make their lives harder, they are less likely to do it. So let's talk about some of the data behind why implementing trauma-informed care benefits all. There are a lot of data out there on the benefits of trauma-informed care, shared decision-making, and patient-centered care and patient outcomes. So I'll share a bit of it with you today. For those who seek evidence for the change they are asked to undertake, these studies help solidify the ask. This study looked at 39 family physicians and 315 of their patients. Office visits were audio taped and scored for patient-centered communication. In addition, patients were asked for their perception of the patient-centeredness of the visit. Patient-centered communication was correlated with the patient's perceptions of finding common ground. In addition, positive perceptions were associated with better recovery from their discomfort and concern, better emotional health 2 months later, and fewer diagnostic tests and referrals. The second study looked at 614 patients and assessed patients' perceptions of autonomy support and autonomy preferences during their healthcare visit. It showed a strong support for the relationship between autonomy support and patient trust, satisfaction, and mental health related quality of life. Specifically, patients given the most involvement in their decisions for their care had greater trust and satisfaction than patients who did not. Patients given more information about their diagnoses and treatment options also had higher level of satisfaction with their care. This study looked at 509 patients and is unique in that it controlled for a lot of demographic and social factors between patients. It used the Davis Observation Code, which is a validated 20-item scale to assess patient-physician interactions, and it found a higher average amount of patient-centered care recorded in visits throughout the one-year study period was related to a significantly decreased annual number of visits for specialty care needs, less frequent hospitalizations, and fewer laboratory and diagnostic tests. Also, total medical charges for the one-year study were also significantly reduced, as were charges for the specialty care clinics. But what about staff wellness? We don't want to make their work life worse, right? We want to make it better. So studies support that everyone, when they implement trauma-informed care, benefits from this. This study took place in a residential addiction treatment facility and had two aims: to operationalize the processes an organization can take to become trauma-informed and assess the impact a multi-year TIC implementation project had on an organizational climate, their procedures, staff and resident satisfaction, and client retention and treatment. Following implementation of trauma-informed care, there were positive changes in each of the 5 outcomes assessed. Workplace satisfaction, climate, and procedures improved by moderate to large effect sizes, while client satisfaction and the number of planned discharges improved significantly. Another study looked at the relationship between staff and job satisfaction, stress, turnover, and staff outcomes when utilizing person-centered care at a nursing home. They assessed this by utilizing Cohen-Mansfield's comprehensive occupational stress model. They found that patient-centered care and empowerment of both staff and patients led to increased job satisfaction in the nursing workforce, and that this was positively related to increased quality of life among the patients and correlated with increased staff satisfaction and staff retention. The study also stated that empowerment is an essential component in the implementation of patient-centered care, and it is fundamental at both the organizational and unit level. When employees are empowered to make creative decisions based on patients' preferences, they become committed to satisfying relationships with patients and colleagues, which ultimately enhances satisfaction for everyone. Now, what about some specific issues when trying to implement trauma-informed care inside FQHCs? First is the documentation requirements. You have the UDS and clinical quality measures and all the additional documentation that comes from being a federally qualified health center. Those add an extra layer of stress and time consumption. I get it, but anytime you can use the HR to work for you, you should do it. In my clinic, we use Cerner, and therefore I have an obscene amount of what is called dot phrases in Cerner. Plenty of them are to make my life easier, like shorter HPIs, common exam findings, and common treatment options and plans based on the problem presented, but also to help my patients with those educational pages we talked about earlier for their symptoms or diagnoses and covering the options for their treatment, like these. Because choice is one of the easiest parts of trauma-informed care. So anything you can do in your EHR to get information typed up quickly and also provide information easily to your patients so they can be empowered in their choices, which honestly just makes your life easier, you should do it. Yes, it is effort up front one time, but it provides knowledge and options to those patients endlessly because you can use it over and over again. Then interpreters. As you all know, any visit when you have to use interpreters doubles the time it takes to complete the visit. This is a ripe situation to try to cut corners with the information you share and also the way you approach these patients. So the no you often get here is any effort that is perceived to make this type of visit longer. Ways to work through this: provide patient education in their native language. This also takes effort up front. This is something I've been working on for years and it's still not done. We have translated many but not all of our educational handouts into our commonly encountered languages. Also, trauma-informed care with interpreters involves explaining the exams and expectations before you touch the patient, which I recognize slows things down. But it's so necessary for equitable care. I do think you can become very intentional with how the clinical team functions with interpreters regarding what is said and how. For example, I explain every step I recommend upfront and also say I will explain again as we go. Then while I'm completing the breast exam, for example, I am already explaining what's going to happen next. You can even have your MA tell the patient about the exam that they expect before you walk in the room while you are with another patient if needed, and this helps shorten your time. Social needs of patients within FQHCs are a great area to offer trauma-informed care. And this is true even outside of FQHCs. Making the resources you have available to your patients visible to all helps with equity as well, so patients don't have to ask what is available. Handouts in negative languages explaining what is available to patients and making any requirements to achieve those services very clear up front is also important. To highlight that trauma-informed care as a practice is something you will always be improving upon and is not an endpoint, I'll share something that we still need to improve in our clinic. We have something called Babes coupons. Pregnant patients get these only at specific prenatal visits, though they aren't informed which ones, and they are given extra coupons if their partner comes with them to the visit. The idea behind this is to encourage partner participation, but to be clear, this is not even remotely trauma-informed for so many reasons, the least of which is the unnecessary burden it puts on a couple who may be missing work, and it provides less coupons to single pregnant folks. It's not even documented in their chart about Babes coupons, so the patient has to speak up at each visit to ask for Babes coupons. It's something we need to fix in our system to provide more equitable and non-judgmental care. And the last one here is staff turnover. This is not totally specific to FQHCs, as this happens in all non-FQHC clinics and hospital spaces as well. But it does add an element of frustration when you train a staff member and then they leave and a new staff member joins and you have to start over. I recommend having the trauma-informed training as a requirement for all new staff. Then teaching them on the job about how we give trauma-informed care is important, and it's easy once you get used to it. It takes me about half a day to show a new MA how I like to approach patients, and then we are in the swing of things. On staff turnover and training new staff, get straight to the key points when you first work with them. For clinic staff, these include what you want them to say to patients. For example, at a first prenatal appointment, this is a great time to set those expectations of what happens during prenatal visits and what the patient can expect at that day's visit. For a guide visit, they may say something about what they are here for to verify expectations are equivalent, and then have your MA review with the patient what they can expect at that visit. That is then less time the provider needs to spend explaining things. For non-clinical staff, key points include introducing themselves when patients check in and also verifying why the patient is there and what they can expect, like where to sit and who's going to call them. This also includes honesty and transparency about an estimated wait time. Providing that transparency helps people feel respected, even if it's a 30-minute wait past their appointment time. And then chaperones. This is not unique to FQHCs, but is still important to discuss. According to ACOG, the American College of OBGYNs, a chaperone is recommended for all breast, genital, and rectal exams. However, chaperones can be tricky for two reasons. Sometimes the clinic flow just does not allow for that, and sometimes a chaperone can actually be re-traumatizing to someone. So I typically ask the patient if they would be okay with the MA who brought them in the room, and I say that person's name, coming back in with me after they get undressed. I occasionally have patients that decline and would rather it be me alone. While I may be putting myself at risk of sexual harassment accusations without a chaperone, I offer and accept informed declination. Autonomy and the right to choose no as well is a key component to trauma-informed care, and so I honor the patient's choice. Another one is burnout. I've run into a lot of people over the years that fear that trying to practice trauma-informed care will either lead to burnout or worsen already existing burnout. But data support exactly the opposite. This is because trauma-informed care allows all people to be respected. It provides honesty and transparency for all members of the care team and for the patients. It decreases anxiety and frustration from patients when they know what to expect at all touch points in their visit. And another common no, people saying TEIC takes too much time. It does not. It takes the same time as a normal visit, and it might even take less if you follow the work smarter, not harder mantra and create those educational handouts about your commonly encountered scenarios or what to expect during certain visits, and work with your medical assistant to review expectations and goals with the patient prior to the provider's arrival. It also helps decrease frustration for patients during their entire encounter when they are approached with respect, honesty, and transparency throughout their entire clinical visit. As we close, I wanted to highlight some trauma-informed care resources that are local and totally free to anyone, and then I'll be happy to take questions. The first is HCET itself. Healthcare Education and Training has a multitude of resources, including this great YouTube channel. Through that channel, you can access webinars, presentations, training videos, etc. They also provide these much prettier resources compared to the simple Word documents I showed you during this presentation that you can also download for free and post in your clinics if you want. And the other resource I wanted to highlight is the Midwest Trauma Informed Training Center, which exists through HCET. And they also provide these training materials and resources, which are just a click away and free. Use this QR code if you would like to connect with Healthcare Education and Training, through which you can connect with Midwest Trauma Informed Training Center, or feel free to email the Midwest Trauma Informed Training Center's director at the email listed here. If you are willing to share what other topics you might like to hear about or what is important to you in your workspace, please use this QR code and fill out a brief survey. And that's all the time we have for today to discuss how to implement trauma-informed care while navigating common points of resistance. So let's summarize with some quick pro tips. In the clinic space, trauma-informed care starts with the waiting room and the reception staff. It's so important to have a welcoming place for all. Come up with verbiage your MA or LPN can use when bringing a patient back from the waiting room, taking their vitals, and taking their history. Remember, as an organization and for providers, your MA represents you. So what do you want your patients to hear? Consider options regarding the scale. Maybe you can offer for patients not to be weighed unless absolutely necessary. Consider signage or cards in the waiting room for this purpose because, again, transparency is trauma-informed care. Explain all recommended exams in detail so the patient knows what to expect. Offer distraction and supportive techniques, such as pain relief when able, visual and audio distractions, and the most common source of that is the patient's own phone. Encourage them to use it if it helps them get through the visit. Written educational materials that explain what to expect during prenatal care or any visit can help alleviate stress. It's also important to provide educational information on the common diagnoses you encounter in your clinic space that ideally includes various treatment options with the pros and cons of each one so that the patient can really digest this information in their own space where they feel the safest and in their own time. And choices. Even when they seem simple or silly to you, like which arm to take their blood pressure on, offering choices whenever you can at any step can really help the patient feel more in control and feel more safe. Recognize you will face resistance whenever you want to make change. That doesn't mean it's not worth it. Try to remember what it is like when you are the patient. Remember what makes you feel safe and comfortable and what doesn't. For organizational change, you've got to form a work group. Set agendas by tapping into everyone willing to share their opinion about what it's like to be a patient, what would feel better as a patient, and what would make each staff member feel safer and happier about their workflow. Involve key stakeholders, including leadership. Identify the priorities in your space and that low-hanging fruit. Some change is easy and quick, and other change takes deliberate dedication and time. Generate that buy-in with staff involvement, delegate tasks, and recognize when people have exemplary practices. Remember that you should never feel that you are good enough in your practice in healthcare. While you are the expert in medicine, the patient is the expert in their own life. We should all strive to always be looking for ways to make our interactions in healthcare feel more safe, more welcoming, and more empowering for our patients. That is the end. I'm happy to take questions. And this is the QR code for the evaluation for this presentation. Feel free to scan this and fill out your evaluation at any time.
Thank you so much, Dr. Conklin. This evaluation that we would love for you all to fill out will also be sent to you in an email tomorrow. And then our colleague Megan has also put the link in the chat if that's easier for you to access. I will wait to see if there are questions coming in as well.
I can't hear you, Kara.
Oh, no worries, Kara. I can take care of this. So some of the resources that Dr. Conklin was showing are temporarily not able to be accessed on our website. We're just making a couple changes. So some of the resources she mentioned about the little cards that a patient can see that talk about like whether or not they want to be weighed and which vital signs they'd like to be used today for their appointment. There's a temporarily not up on our website just as some changes that we are making. See, I'll just wait a couple minutes before some questions come in. Oh, and then also you'll see in the chat, if people would like the resources, let's say you don't want to wait for them to come back on our website, they can email the director of our Midwest Trauma Informed Training Center, Kara Berg-Ronick, and she put her email right here in the chat.
Thanks so much, Adele.
We can hear you now.
Yeah, we
Yay!
can hear you now. Go
Well
ahead.
done. Hi, everyone. My name is Kara Berg-Ronick. I'm the director of the Midwest Trauma Informed Training Center. Thank you so much, Dr. Conklin. That was amazing. And yeah, everything Adele said, please feel free to email me and I will make sure that you get all the resources right away. Thanks so much.
And since the link for the evaluation is actually in the chat, I'm going to go ahead and go back to the survey link for future topics, if that's okay. many clicks later. There we go. Any other questions, comments? Anybody wants to speak up about any topics they'd like to hear in the future? We're happy to hear it, and even now.
Adele, you're muted.
Hannah, I'm just going to speak your comment out loud because other people might be having the same thought. Hannah says, I find it very interesting that my assumption was that the no you referred to in your presentation title was the patient refusal. So important to discuss provider no's as well. Thank you for today. Oh, okay. So Chris from Indy, they have a suggestion. This for her topic, this for community health workers and non-medical case managers.
Yeah, I love that. We can definitely work on that.
Wonderful. We have a couple minutes if people want to put in questions too, or keep using the chat. Thank you all so much. Oh, thank you. Excellent presentation. Thank you so much. I'm so glad all of you could join us. I always learn a lot from hearing this, this talk, Dr. Conklin. Thank you so much.
Of course.
And we are recording this. You are able to access our presentations on our YouTube channel. It usually takes a couple of days to go up. But if you go to YouTube and search HCET, you can find a lot of trainings there that we do. Thank you all so much for making the time to come today. Again, too, if you have questions that you don't want to ask the group, up in the chat, you'll see Dr. Kara Bergronick did put her email. You're also able to ask her questions at that email, and then she can also pass questions along to Dr. Conklin as well, if you have questions for Dr. Conklin that you don't want to speak right now. Okay.
I just put my email in the chat too. Happy to talk directly with folks.
Okay. Oh, thank you, Dr. Conklin. Wonderful. In case you are trying to decide if you have a question whether to use chat or Q&A, the Q&A function lets you submit a question anonymously. So if you put a question using the Q&A, we don't see your identity if that's preferred. I am going to really quickly link our YouTube page since some things are currently not on our website, just in case you want to check out recordings on our YouTube page. One moment, please. Okay, the link I just pasted is our YouTube channel where you can find a lot of the recordings of trainings we already have done, including other ones from the Midwest Trauma-Informed Training Center.
And while we're talking about all the webinars, our next presentation coming up will be on brain science and resilience. And that will be March 19th, sorry. So you can look for signups coming your way.
I'm really excited to hear that one. Thank you for reminding us, giving us a little teaser for the next topic. If we don't have any more questions, we can give you all back about 5 minutes to your day. Again, you have the links in the chat. I'll leave the chat up. We'll stay here for a couple of minutes so people can access those links. But thank you so much for taking the time to be with us today. I really appreciate your time, Dr. Conklin, Kara. I love listening to these. I always learn a lot. Thank you so much for your time and sharing your experiences and your wisdom. And thank you all for coming and chatting with us today. We'll see you very soon.